So again, my name is Jesse O'Brien. I'm OSPIRG's healthcare advocate. OSPIRG is the Oregon State Public Interest Research Group. If you're not familiar with the acronym, it dates back to the early 70s, back when people apparently thought that long acronyms were a good idea. But OSPIRG is Oregon's public interest advocacy group. We're a statewide grassroots nonprofit advocacy organization, been around for over 40 years. And we work on a pretty broad range of issues, public interest being a pretty broad concept, of course, but I manage our healthcare program, which is mostly about, as the introduction said, trying to do something about the high cost of healthcare in Oregon and making healthcare work better for consumers, but we also try to empower consumers with information that will help them access affordable health coverage and use the healthcare system more effectively to meet their needs and keep themselves healthy. So that's what this is about. So this presentation, I should back up just a bit. This is sort of a hybrid between a presentation that I've been giving to what you might call members of the general public, just people who want to come in and learn more about health insurance. But I'm also going to, since this is a more savvy group and you work with people who may have questions about health insurance, I'm also going to talk more about how to talk to people about these concepts, which I hope is helpful. One thing I was curious about is how many of you in your work with Elders in Action have answered questions or tried to help people through questions having to do with health insurance? Great. Have any of you actually helped anyone sign up for health insurance? Great.
Long ago when it was actually working.
Right. Well, we're trying to make it work again, work in a new way. One thing to keep in mind is that the open enrollment period for the Affordable Care Act, so-called Obamacare, is coming up pretty soon, and there's probably going to be a lot of questions that people have about that. You may get some calls as an advocate, so hopefully this will help prepare you for that. The open enrollment period starts November 15th and goes through February 15th. But the most important period in that open enrollment period is going to be November 15th through December 15th, because you have to enroll by December 15th to have coverage starting in January. So some people will, so there are a lot of people who are going to have to enroll during that first month in order to have continuous coverage or to not miss a month or two of coverage. So that first month is going to be very busy. You may get a lot of questions. Just giving you a warning. Also, I don't want this to be a lecture at all. Feel free to interrupt me at any point. Normally when I do this presentation with members of the general public, I try to save questions until breaks in the presentation, but
all right,
yes?
So
go for it.
That, what happens between January 15th what happens in that gap on the outside?
You mean...
If you need to sign up by December 15th to get coverage by January, what happens between January and
Yeah, so
February?
if you sign up after that deadline, if you sign up on December 16th,
Yeah.
then your coverage won't start until February 1st. So
you
you would
miss a month.
You'd miss a month,
Okay.
yeah. And that's not necessarily the end of the world, but if you get hit by a bus, God forbid, during that month, it could be pretty bad. So these are the topics I'm going to cover. By the way, please let me know if I'm going way over time or anything like that. I'm going to start with a section on the really bare bones basics of what health insurance is, how it works. Then some more detailed discussion of how to use your health insurance to access coverage. And then an overview of health reform, so-called Obamacare, the Affordable Care Act. One thing I always say from the get-go is, that's a very politicized subject, obviously. There's a big national argument about the merits or demerits of health reform, but that's not what I'm here to talk about today. I'm just here to talk about what's actually happening and how it affects health insurance consumers. I'd be happy to talk about the politics of it some other time, but that's not what this is about. And then finally, a little bit about shopping for health insurance and how to pick a plan that's right for you. Okay, like I said, feel free to interrupt me at any point. One other thing is I have an enormous number of handouts that you may or may not find useful. I didn't want to kill all of the trees necessary to bring them to this event in paper form, but if everybody would be interested in having access to these, we can have them emailed out to the whole list. Otherwise, just come up to me afterwards individually. Maybe I'll take a poll at the end and see what people think. Okay, so what is health insurance and why do people need it? I think this might seem like something that you don't need to explain to people, but I think some people really don't get the fundamental thing. The reason that people need health insurance is because the cost of healthcare is just absolutely prohibitive if you have to pay for everything out of pocket. And I think a lot of people who are younger folks or people who are lucky enough to not have had to go to the doctor or the hospital very often aren't aware of the fact that healthcare costs as much as it does. A single trip to the emergency room, even for a pretty minor thing, can cost thousands of dollars. And I've seen that happen to my friends, it's happened to me before. What health insurance does is it's a way of protecting yourself from that financial risk by paying a small amount of money up front every month. It's called premium. That goes into a pool with everybody else who has the same insurance. And then whenever one of you has to access a healthcare service, you get sick, you get injured, at least part of the cost of that is covered by the money that's in that pool. So it's a way of sharing risk. And that makes it sound like it's very kind of touchy-feely, we're all in this together, and that's not necessarily the way it actually feels when you're interacting with the system, which is unfortunate, but that's the basic idea. The basic idea is a group of people pooling their money together because you never know when you're going to get sick, but you know that you are going to get sick or injured at some point because everybody does, unfortunately. When you do, you'll be protected because enough people are paying into the pool that it can cover those costs. So there are a lot of different kinds of health coverage in the United States. The United States has a tremendously fragmented health insurance system. Most Americans get their health coverage through commercial insurance, and there are a number of different kinds of commercial insurance. Most Americans, again, get their commercial insurance through their employer, through their work, as part of a benefits package. I divide that up into small employer and large employer because those kinds of insurance are actually very different. If you work for a large corporation like Intel or Nike, they are in a very different position and have a very different kind of insurance because they have so many employees. They can go to the insurance company and say, if you want our business, if you want the thousands of people that we employ as part of your pool, then you're going to have to give us a good deal. A small employer, an employer with just a few people, is not in that position at all. The insurance company doesn't need their business that much if it's only 5 people or something. And Oregon is a small business state, so a lot of us are in that position. For this reason, these two kinds of coverage often look really different. Small business coverage is usually not nearly as good. It can be quite expensive, and it's also regulated differently. And then finally, there's individual and family coverage, which is the kind of coverage that you get if you just, as an individual or as a family, go to an insurance company and pay the whole premium yourself. For many years, for decades, this was by far the hardest part of the market to be in as a consumer because there's the problem that small employers have, where the insurance company doesn't need your business that bad because you're just one person or a family. So the quality is not necessarily going to be very good. The price might be very high. But the other thing is that for many years, this was the market where you could be denied coverage for having a pre-existing health condition. That's no longer the case, which is great, but there's still some problems with that insurance.
Yeah. Since there's inequity there, and Oregon has lots of small businesses, is there any move or possibility to combine the pool, where a small business goes in with Intel or something like that?
There have been some discussions of that kind of thing. There's also been a discussion about merging the individual and family pool with the small business pool. The details there are kind of technical, but it might happen at some point. Oregon also has, although the situation is certainly not rosy by any means, it does have some of the more consumer protective health insurance regulations in the country. So we do have some protections around small employers and individuals and families not being overcharged, which I can go into more detail about if you want. But
can we get the smaller ones all that can be one? Instead of joining with Intel just being their own group?
yeah, like an association sort of thing. There are some setups like that. I don't really want to go into the details, but I know in Bend, for instance, the Bend Chamber of Commerce has an association plan that a bunch of small businesses buy into. There's a problem with that, which is that those plans aren't regulated very well, so sometimes they actually work worse for the small businesses than the small business plans. I think that might be fixable, but in any event, that's where we are. So those are the different kinds of commercial insurance. There are also a number of different kinds of public coverage, that is basically government-funded health coverage. The most relevant of which for our discussion is, of course, Medicare, which is government-provided health insurance for Americans over the age of 65. I'm not actually going to talk about Medicare very much, although I'm happy to try to answer questions about it, because this presentation is mostly about commercial insurance. But some of the same issues come up because, as I'm sure all of you know, a lot of people who have Medicare also have what's called Medicare Advantage, which is basically a commercial insurance company providing the Medicare benefits, usually with some supplements on top of them. So the questions about how you interact with the health insurance system are pretty similar if you look at Medicare Advantage. There are a number of other kinds of public coverage. In Oregon, we have the Oregon Health Plan, OHP, and Oregon Healthy Kids. These are programs for low-income Oregonians and children. They're basically free or very, very low-cost health coverage for those folks. Those are state state versions of national programs called Medicaid and CHIP, or the Children's Health Insurance Program. And in Oregon, we have a somewhat unique situation with the way those work. Each state implements those programs a little bit differently. In Oregon, the Oregon Health Plan is run by a set of regional organizations called Coordinated Care Organizations, or CCOs. In the Portland area, there's two of them. There's Health Share and Family Care, and they're these sort of complicated cooperative entities with hospitals and insurance companies and a bunch of other providers all working together with what's called a global budget, where they have a set amount of money to take care of the medical needs of all of the people who are eligible for the Oregon Health Plan in their area. And then they're held accountable for keeping them healthy. And the idea is that changes the incentive so that they try to spend money on prevention, because if they save money, they can keep that money down the line. But it's important to hold them accountable, because otherwise they would just not provide people with health care and pocket the difference. So I'm not going to go into great detail about Medicaid or CHIP or the coordinated care organizations, but they are part of the landscape. And the coordinated care organization model is something that our governor is very interested in trying to move into the commercial health insurance world as well in various ways. So we'll probably be hearing more and more of that over the next few years. Although, how the election goes may change that, who knows. More health insurance basics. Most of the key common terms having to do with health insurance have to do with money, because health insurance is primarily a financial product. I mean, I think ideally we would like to think of our insurance company as a company devoted to keeping us healthy, giving us tools and resources to live life to its fullest and so forth. In reality, that's not necessarily the way it plays out, and your primary sort of interaction with the insurance company is based on money more so than health. But these are some of the most basic terms. I already talked a little bit about a premium. A premium is basically just the sticker price, if you will, for having health insurance coverage at all. It's a small, usually larger than we'd like, but relatively small monthly fee that you pay to have health insurance at all. Sometimes people who aren't very familiar with health insurance think that you only have to pay the premium if you use your health insurance in that month. That could be a very costly mistake for people, so that's something that you definitely want to remind people not to do. If you want to have health insurance coverage, you have to pay your premium every month, even if you don't actually use the coverage. So the premium is definitely the easiest term to understand there. I think most people get it. There are, however, a lot of other ways that insurance companies share the cost of providing health coverage, of providing health care with their members. Sharing is sort of a euphemistic way of putting it. Makes it sound like a nice, gentle thing to do, but really it's just charging you more for access to health care. And this can take a bunch of different forms. The simplest is called a copay, which is just a set fee for a given service that you pay every time you go to the doctor, go to the hospital, go to the clinic, what have you. So you might have a $10 copay to see your primary care doctor, for example. And that's pretty simple. You just pay the $10 every time you go to see that doctor, and that's it. A lot of health insurance plans will have different copays for different kinds of services. So, there might be a $10 copay for a primary care doctor. There might be a $50 copay for a specialist. Some health insurance plans have copays for everything. So there will be maybe like a $500 copay for an emergency room visit or something like that. That's fairly unusual, but it does happen. And the thing with the copay is you know what you're going to pay before you have to pay it, and it's just the one set fee. Slightly more complicated is the deductible. So a deductible is the point at which your health insurance starts covering the cost of the healthcare that the healthcare services that you receive. So I have a little graphic to try to explain how this works. This is one of those terms that people get really confused by. So suppose you have a health insurance plan with a deductible of $1,000. I don't know if you all can read this, but hopefully it'll be fairly straightforward. What that means is you pay everything up to that $1,000 mark. And what is everything? Well, everything is the actual cost of the underlying healthcare service. So if you have this plan with a $1,000 deductible and you have to go to the emergency room and you have some stitches or what have you, and it winds up costing $1,000, you pay the whole thing. Until you reach the deductible, you pay the whole thing. The insurance company pays nothing.
That's per visit, right?
No, it is not per visit.
Oh.
It is per year.
Deductible per year.
Yeah. The issue with this is that you don't necessarily know what the underlying cost of the procedure is, and it can be difficult to find out. if you ask, I don't know if any of you have had this experience of asking a doctor, asking a hospital official or something what something's going to cost. They often don't know. It can take a long time for them to figure it out, and they're usually really surprised by the question, which is unfortunate. We're trying to do something about that, by the way. You may hear more about that in the months to come. Trying to make that information more publicly available. But the basic idea of a deductible is pretty simple. Like you're probably going to have to pay all of that over the course of the year if you're going to be using healthcare services. So if you have a $1,000 deductible, you can expect to pay about $1,000 a year, unless you're someone who almost never uses health insurance. The other thing about the deductible is there can be different forms of it. So you can have an individual deductible or a family deductible. If you have a plan that covers your whole family, there might be a separate deductible for each person, which can be fairly confusing. So, for example, you might have, say you have 5 people in your family, you have a $1,000 overall deductible. That might be broken down to a $200 deductible for each person, which is just very confusing for people, but that's something that can happen. So if one of those people spends $200, then they've met their deductible and the insurance starts kicking in for them. The other thing is that some plans have different deductibles for medical care and prescription drug coverage. Usually there's a lower deductible for prescription drug coverage because basically because insurance companies don't want to disincentivize people from using prescription drugs that can keep them out of the hospital. That's supposed to be the idea. But sometimes they're combined, in which case, if you were buying a particularly expensive drug, you would have to pay up to the $1,000 deductible in that case.
I'm curious about the copay with the deductible. Once you've met the deductible, and you go back in for a regular visit of some kind, I don't know, see a dermatologist, someone, whatever, are you still paying the copay? That's my question. I get confused with that.
Usually a copay is carved out of the deductible, so you just pay the copay and you don't pay the deductible. Sometimes everything is under the deductible, so you have to pay up to the deductible and then you start paying the copay every time you see the doctor.
But if you're seeing the copay in the beginning and just the copay, and then you meet the deductible?
Yeah, usually just paying the copay doesn't count toward the deductible.
And also preventative care isn't.
And also I'm going to get to that in a few minutes. The other thing is, and this is something I'll talk about in a little bit more detail later, is that frequently the deductible only applies to in-network healthcare. So if you have a network plan where you're supposed to see where you're only allowed to see a small group of providers or what have you, the deductible only applies there. And if you go out of that network, there's a different deductible that's usually much higher. So then, final basic cost-sharing term is coinsurance. Coinsurance is even more complicated. The basic idea is pretty simple, but how it plays out when you're actually accessing healthcare can be kind of complicated. So coinsurance is a percentage of the cost of a healthcare service that you're expected to pay, even past the point when you've hit the deductible. If you have, say, a 20% coinsurance, then once you've hit that $1,000 deductible, the insurer will pay 80%, you will pay 20% of whatever that underlying cost is. So say you go to the emergency room, you get a bill for $2,000, and you have this plan where you have a $1,000 deductible and 20% coinsurance. You pay the first $1,000, all of it out of pocket, and then you pay 20% of the rest, which in this case is $200, so your total out of pocket would be $1,200. And in that case, it doesn't seem like health insurance is actually buying you all that much because it's just reducing your cost from $2,000 to $1,200. But if you have to go to the emergency room again, God forbid, and get another $2,000 bill, the insurance will cover the majority of it.
All but 20%.
Right, all but 20% in that case. And the thing with coinsurance is that Sometimes there will be different rates of coinsurance for different kinds of services, which can be kind of confusing for people. So you may have, a 20% coinsurance for seeing a specialist that you're referred to by your primary care doc or something like that, but you might have a 50% coinsurance for the emergency room or something like that. That's not uncommon at all. So then the final concept here is the out-of-pocket maximum. Sorry.
I'm sorry. Is it a general rule that the copay is the same for specialists as GPs, or is it a difference?
It's usually different. It depends on the plan, though.
Okay. Thank you.
Usually there's a lower copay for the primary care doc than for the specialist. So the out-of-pocket maximum is actually a fairly new concept that, the term has been out there for a while, but there's, thanks to the Affordable Care Act, there's a new kind of out-of-pocket maximum that every small business and individual and family plan has to have, where there's an absolute hard cap on the amount of money that you have to pay out of pocket in a year. For an individual, it's $6,600 for this next year. It'll go up slowly every year to try to adjust for inflation. So what this means is, with this plan, where you have a $1,000 deductible, you pay the first $1,000, you pay 20% of the rest, but once you've paid up to $6,600, you don't have to pay anything more. The insurance company picks up all of the rest of it. That's just for an individual. For a family, it's twice that. So it's $13,200. And that's the cap that's in the law. There are companies that have, there are plans that have a lower out-of-pocket maximum than that. Since the out-of-pocket maximum is a really important consumer protection, some people may want to seek out a plan that has a lower out-of-pocket maximum. One thing that's really important and new about this out-of-pocket maximum is that it takes into account everything. It's co-pays, it's your payment toward the deductible, it's all of your co-insurance, it's everything. Once you hit that cap, you're done.
And does the insurance company tell you when you hit the cap, or do you just have to know it?
They should stop charging you once you hit the cap. Whether they actually do, you definitely want to keep an eye on it.
Is there still a maximum for the insurance, I don't remember what you call it, but I know sometimes with patients, they'll reach $1 million, and then the insurance company says, well, we're only covering $850,000, we're stopping your insurance or we're selling you to someone else, that
Right.
kind of thing.
That is no longer legal.
Oh, okay.
It used to be that you could have a lifetime limit or an annual limit, where there was a limit to how much the insurance company would pay over the course of a year or over the course of a lifetime. For instance, it used to be pretty common for an insurance company to have a $2 million annual limit. Most people are not going to get anywhere near that limit anyway, but if you have a family where God forbid the whole family gets in a terrible car accident and everyone needs surgery or something, you could hit that point. And then to add insult to injury, almost literally, your insurance company would stop paying for it at a certain point. But that's no longer legal. There are, under the Affordable Care Act, there are still some plans that are out there that people have that have those limits in them. That it's only maybe 30,000 people in Oregon or something like that, but there was a decision made to allow insurance companies to continue offering pre-Affordable Care Act plans to people who had those plans. You might have heard about this, and those people may still have those limits.
You stated for one individual 6,000 and family 13. Does it depend on how many is in the family, or that's?
It does not depend on how many people are in the family.
Good.
Okay. So I'll go through this a little bit faster. These are some of the basic terms having to do with access to care. I like to define the term provider briefly, because I think people sometimes don't get what you're talking about there. A healthcare provider is just any person or institution or facility that provides a healthcare service. So it's a doctor, it's a hospital, it's a clinic, it's a nurse, it's a chiropractor, it's a naturopath, it's whoever is providing the service that the insurance company is covering it for. It's a kind of an abstract term that people in healthcare throw around a lot that the average person might not fully understand. And then a service, another very abstract term. A healthcare service is just anything that you're going to get billed for, or that the hospital, clinic, or doctor is going to bill your insurance company for. So it could be, a visit with your doctor, a visit with a nurse practitioner. It could be a prescription that you get. It could be a surgery. It could be a phone call with your doctor, or a Skype visit with your doctor, or even in some cases an email exchange with your doctor. It's any kind of interaction that you have with the healthcare system where somebody owes somebody else some money as a result of it. And then a really important term is the network. It used to be the case that most health insurance plans would just pay for you to go to see any provider. That is almost totally unheard of these days. Most health insurance companies have a network, or sometimes multiple networks of providers that they try to direct people to because they think they're lower cost or higher quality, or they can get a better deal from those providers or something like that. And the way this works is usually, you can, if you have a health insurance plan with a network, you can go to an in-network provider or an out-of-network provider, but you may have to pay a whole lot more for the out-of-network provider, and in some cases, you may have to just pick up the whole cost, and the insurance company won't cover it all. It depends on how your insurance plan is set up. And I'm going to get into more detail about that in a minute. But there's also this concept of having a wide network of providers versus a narrow network. So a wide network is, you look at the list of providers you can go to in the insurance company's guide, and it just goes on forever. You can see lots of people. In a narrow network, there may be just a few providers in each category that the insurance company has, and you're expected to go to one of them. Usually, a narrow network health insurance plan is going to cost less because the insurance company can get a sort of bulk discount from those providers by saying, we're going to send everybody to you. I'm not going to say that a wide network is good, a narrow network is bad, or the reverse. It depends on the person's needs and who actually is in the network. So if you have a doctor that you really want to stay with and that doctor isn't in the narrow network, then that could be a problem. If you have some kind of chronic condition where you have to see the doctor all the time, then the narrow network might also be a problem, because sometimes you can have longer wait times because there are just fewer doctors divided up among all the members. But if you're not in that position, then a narrow network might be better because it's cheaper. It kind of depends on how you work with the health insurance system.
Wouldn't the whole network be inclusive of all states?
So this is something I wish I knew a little bit more about. There's some sort of regulations about insurance companies covering healthcare services when people are traveling, especially emergency care. I don't really understand the details as well as I could.
I don't mean international travel, I'm talking domestic.
In the U.S.
Domestic
In the U.S., that's also true. But I don't know the details as well as I should. There are some insurance companies that have an actual national network. If you're signed up with a national plan, like Aetna, that sort of Blue Cross, Blue Cross, then there'll be a network in all 50 states. But some of the smaller plans don't have their own network in other states, but they have some sort of arrangement to pay for emergency services or what have you. So like Moda, for instance, which is a big plan here, they're just a regional insurance company, but if you were traveling in New York or something and got in a car accident, they would cover that. Any other questions before I move on? Oh, yeah.
A question on when you pay, because I'm thinking you're in network, they pay up front and you don't owe anything. But if you're out of network or have something, sometimes you have to pay the whole thing up front and then get reimbursed by
That's
your
true.
insurance carrier,
Right.
which can be very expensive.
Yeah.
And time-consuming and long delay.
And also, sometimes you think that someone's in the network and they're not. And you pay, the copay up front, and then you get a bill from the doctor or the hospital down the line, which is very confusing and frustrating for people. But that's something I'll talk about a little bit more in a minute.
Or you think certain services are covered and they're not.
Right. Okay, so this is a good transition to the next section on using your health insurance. So the biggest thing here, the thing that trips people up the most, is the provider network, figuring out who you can see, how much it's going to cost, who's in the network, who's out of the network. So in theory, this should be pretty easy. You should be able to go to your insurance company, get a list of everybody who's in the network, and what cost it's going to be. In practice, it is way more complicated than that, which is very frustrating. And this is, I imagine that some of the people who contact you for help navigating health insurance are going to be asking questions about this. So every insurance company has to have a provider directory that they make available in written form and online. So you can just go to the insurance company's website. If you're a member, you can log in, and it'll give you a list of everyone you can see. And it also, because sometimes insurance companies will have what's called a tiered provider network. So there'll be the preferred providers, the tier 1 providers, who they really want you to go see. And you'll pay the smallest amount of money to go to them. So you might have like a $10 copay to see those folks. Then there'll be a second tier of less preferred providers where you might pay $25, $50, something like that. And there could be a third tier. There could, in some situations, be a fourth tier. And then there's everyone who's out of network. And the provider directory should give you the full list and which tier everybody is in and how much that will cost. The problem is, and this has been documented very well in the past year, the provider directories are just always wrong. They're not kept up to date. Sometimes they're just silly errors, like listing the wrong specialty, or listing someone who's actually out of state, listing someone who's been dead for years. This kind of thing happens all the time. It's a big problem.
Or a number that's a pizza party.
There's actually an effort right now to in Oregon, to try to get some more accountability around this so that there's more transparency. That's something that I'm working on. We'll see how it goes. But I think the best advice you could give to a consumer is check with everyone. Don't trust the provider directory. Also, call the insurance company and the provider, him or herself. And hopefully you can get to the bottom of it that way. In a lot of situations, it's not going to matter that much, but if it's a big surgery that you're planning in advance or something like that, you really want to make sure that you're not going to have to pay for the thing out of pocket. Okay. I think that's it for the basics of the provider network.
Usually if it's a procedure that they have to do, don't they like pre-qualify with the insurance company to make sure you are covered and
Before they do it.
before they do
That's true with
the
Medicare.
surgery?
It depends on the insurance plan. If you have like an HMO, which I'm going to be talking about in a second, they usually have some sort of pre-certification requirements. If you have a more traditional health plan, you don't necessarily have to have that. And also, one thing that happens to people a lot is there's one other thing I need to talk about with this, but they will check to make sure that everything is covered in network, and they'll have their surgery in the hospital or what have you, but and everybody, the hospital will be covered, the surgeon will be covered, etc., but some other person involved in it won't be covered. So the anesthesiologist is the classic example of this. Anesthesiologists are frequently not in networks at all, but people don't know that, and even people who know that there's an issue here, that you need to pay attention to this, often get caught paying these huge out-of-network bills. So we just got to remind people to be vigilant about this, because it's really easy to get caught. And hopefully we can change the system so that this kind of thing stops happening to people, but I think we're a ways away from that right now, unfortunately.
I was just curious about the accountability in the tier network. I've heard of patients coming back where the tier network A, there's no one left who are seeing patients.
Right.
So then they're forced to go to tier 2 or 3, which costs them 2 or 3 times as much. So.
Yeah, but there has been a proposal to make it so that if you can't find anyone in the top tier, that the insurance company would be required to offer tier 1 level coverage to people in tier 2. Oregon doesn't have that yet, but I think some other states do. We'll see. The other really important thing about providing networks that confuses consumers is that a single insurance company may actually have more than one provider network. Each plan that they offer can have a separate network. So I talked to an OSPRC member a while back who did everything that you really ought to be expected to do when shopping for health insurance, because he has a chronic condition where he has to go to this one specific clinic where the only provider that does this is at OHSU. So he really needed to have that clinic in his network, and he called the clinic. He talked to some friends and family who had different health insurances, and he figured out that it was in HealthNet's network. I'll just name the specific insurer in this case. So he bought a HealthNet plan off of the health insurance exchange, Cover Oregon, but he bought the wrong plan. He bought their HMO style plan, which doesn't include this clinic. So even though he did all of the research that you could reasonably expect someone to do, he wasn't able to go to his clinic at the in-network rate. And this kind of thing happens to people all the time. It's something that we need to create some more upfront transparency so people know what they're buying. But if you're talking to people who are in the process of shopping for insurance, this is something to remind people. An insurance company doesn't just have one network. They may have a whole bunch of different networks.
And under Covered Oregon, you can't change that until the next year?
If it's during the open enrollment period, you can change. So if this year, for instance, if you bought a plan on November 15th, found out within a month that it didn't cover what you expected it to, you could go back and switch. But if it's after the end of the open enrollment period, then you have to wait until the next one.
Even if it's within the same provider or carrier?
Yeah.
If we do it for you, we have to do it for everybody.
Yeah.
But they should.
Jesse, is there any restriction on how many times one can change? I mean, if you just wait the full year, you could change every year?
Okay, you could change every year.
Okay.
Yeah.
And also, if you, I think I'll be getting to this later in the presentation, but this is a good point to point it out. If you have a life change, you can switch at any time. So if you get married, if you get divorced, if you have a kid, if you lose your job, you can switch. And you have to go through a process through the exchange to prove that happened to you, but then you can have a 60-day special open enrollment period. A lot of people don't know that, so that's something that we really need to get the word out.
So all that guy had to do was get married?
Yeah. If you got married, there's a whole list of things that can trigger the special enrollment period. Okay, so the other big thing about navigating your coverage details is the formulary, which is like the provider network except for prescription drugs. Formulary is the document that tells you what prescription drugs are covered and at what cost. When I do this presentation for the general public, I pull up an actual example of a formulary document, which I'm not going to bother doing right now, but they're very, very long, like ridiculously long, because they have to tell you whether basically every prescription drug that's out there is covered or not, and at what cost. But the way you use it is, I don't think that anyone should be expected to actually read the whole thing before signing up for a health insurance plan. But if you know that you have a specific prescription drug that you need, you can search through the formulary and it'll tell you whether it's covered and at what cost. And usually what the formulary says is whether the drug is a tier 1 drug, tier 2 drug, tier 3 drug, or what have you, and whether it's covered at all. Sometimes it won't be covered. And usually you have to check the formulary back against the way the plan is designed. So the plan will say, a tier 1 drug is a $50 copay, for instance, but the formulary itself will just tell you whether something is a tier 1 drug or not, so you have to look at both at once. Does that make sense?
I had an experience recently where I bought a drug, I changed health plans, and I went to buy a drug that I usually bought in 3-month increments. And when I went to pay for the 3-month increment, they said they were going to charge me almost $70, and I just had sticker shock. And I was like, whoa, what is that? They took it back, they looked at my prescription formula, or whatever it's called, and they said, if you buy 1-month increments, you only pay a $10 copay each time. If you buy 3 months, it'll cost you $70, and I thought, well, the math is bad on that one. In this case, buying bulk does not help you, and so I just go back every month. But so it's an interesting thing that I would imagine older adults would get hit with
Definitely.
a lot if they didn't check with the pharmacist and say, why did this go from 10 to 60? I don't get it.
Yeah, formularies also change sometimes quite rapidly because there's this whole incredibly convoluted backroom negotiation constantly going on between the insurance companies and the drug manufacturers. People can wind up in a position where they buy a plan because they think they're only going to have a $10 copay for their drug, and then the next month that changes for some reason, which is a big problem. There are some states, Oregon is not one of them yet, where insurance companies are prohibited from changing the formulary more frequently than every year, I think, or maybe every month in some cases.
Once a year.
Yeah, it's once a year.
They were not allowed to change it every month.
In Oregon, you're allowed to change it pretty quick.
Just one clarification, because I take multiple medications, and mine are technically formulary, and I think the definition that you're using might be a little off, because when I found out with my plan that I'm on, when I started at the beginning of the year, I had to find out what formulary and what wasn't formulary.
Right.
And they said formulary is what the drugs that I am on, because there are no generics for it. And so the formulary are drugs that do not have a generic. Non-formulary is everything else that has a generic. That's basically how they described it to me, because on mine I can't, because I get the higher premium
Right.
that I have to pay for mine every month, so.
I'm not sure that I've heard the term used that way, but it's...
Well, it was a sticker shock, going from $25 for regular meds to $75 for every med.
Yeah,
So,
yeah, I mean...
and that's why they sort of described it to me as like what a formulary is, like, oh my God, all mine are formulary.
Yeah. Usually, health plans will cover generic drugs at a much lower cost, and it's less of an issue whether they're included in the plan or not, because they almost always are. And sometimes people have an attachment to the idea of having the brand name drug instead of the generic drug, and that can be an issue. But it's also possible for some people to be allergic to the generic and not allergic to the brand name drug. I don't know. I'm just going to move on.
Your doctor also has to make a specific request he can't just write you a prescription, he has to put dispense as written, or he has to write it's exactly what you need to get. Because once you got to the pharmacy, they automatically go for the generic.
Right.
Because it's the law, it's required that they go for the generic first.
Yeah, which is usually good for consumers because it's much cheaper, but you know, there are those situations where it's not.
And forgive me, but this is coming from, I just spent 28 years at Pfizer, so I can tell you that
Right.
people are mistaken when they think that generic drugs and regular formulary drugs are the same, and they're not.
They're not, it's
They're
true.
not all the same, and sometimes they do you more harm than good. But you also have to be vigilant with that. You have to do your own homework, and you have to make sure that your doctor is on top of the drug list as well, to know
Right.
that.
Okay, so other key documents to navigate, to use to navigate your health coverage are the Summary of Benefits and Coverage, or SBC, which is kind of the high-level description of what the plan covers and at what cost. Normally I pull one of those up and show it to people, but I didn't have a chance to pull one up before doing this presentation. But basically what it will do, what the SBC does is there's a standardized format that every health insurance plan has to display this in, and for each kind of service it will say whether it's covered and at what cost sharing level. So if there's no cost, it'll say no cost. If there's a 50% co-insurance, it'll say that. If there's a difference between you know, the tiers of providers for that service, it'll explain that. And one thing that's really useful with the SBC is there are a lot of Oregonians who care a lot about having access to so-called you know, non-traditional healthcare, naturopaths, chiropractors, acupuncturists, etc. And there's a bunch of lines near the bottom of the SBC that say whether those are covered or not. So that's the place, that's the go-to place to go to check on that. It'll also tell you the specific coverage levels, the specific costs for each tier of providers and each tier of the formulary. And it's a very useful document. It's the standardized format is about 6 pages for each health insurance plan, and it might look a little bit intimidating, but it's actually, you know, pretty plain language. I think it's a good go-to thing to direct consumers to look at. And then the explanation of benefits is another key concept. People find explanation of benefits documents pretty confusing. What they are is a description that you get in the mail usually after you go and use your health coverage to access the healthcare service. And they look like a bill, but they say at the top, this is not a bill. And that